مساء الخير، أهلا وسهلا بكم في هذه الأمسية. محدثنا الليلة الدكتور أمين الحيحي، وهو استشاري الطب النفسي في المملكة المتحدة. وهذا لا يعني أنه إنجليزي، هو فلسطيني في المملكة المتحدة. وسيتحدث عن ورقة عدها Characteristic of Young Adults Attending Mental Health Urgent Care Center Clinical Profile Risk Factor and Service Implication. تفضل دكتور أمين.
شكرا جزيلا دكتور وليد، وأنا فعلا سعيد جدا أني أكون مع حضرتك في هذا اللقاء. وأتمنى للجميع أنهم يكونوا يستفيدوا من هذا المحاضرة في عملهم اليومي. زي ما نفهم من عنوان الحلقة، أنه أنا بحاول أني أوضح شيء معين للكوميشنرز في التراست، منشان انه نعمل بروجكت حول اليونج ادلتس، لانه الكوميشنرز nowadays في بريطانيا بدهم الايفيدنس دائما، مشان يقوموا في اعمال جديدة من وقت لوقت. الحقيقة أنا من في خلال 3 4 سنين من أيام الكوفيد صرت أعمل في التراست. لما يكون في حاجات صعبة في بعض السيرفيسز، كنت أتقدم وأعمل فيها البحوثات والأعمال في الكوميونتي. فاشتغلت في الفيرست ابيسود سايكوسيس، واشتغلت في السنجل بوينت اوف اكسس تو ذا mental health services، وعملت بحث كمان هناك. والآن بعمل في الارجنت كير سنتر اللي هو جديد بالنسبة لكل بريطانيا، والترست عندنا هون في هارتفيشر. طبعا هم اليونج بيبل لما suffering from a mental illness, they find it extremely difficult to go to A&E and the emergency department and to wait long hours منشان يشوفوا الليزون سايكاتري زي ما بيحصل هون في بريطانيا. فبحسوا انه في ديستريس بصير عليهم من موضوع الويتنج. وبعدين لما يكونوا جالسين بيحاولوا انهم ينشافوا من الليزون سايكاتري، في ناس بجنبهم بيكونوا مرضى في physical health problems، اللي بيكون عنده مكسور رجله ولا كذا. فبالتالي بحسوا انهم بيضيعوا وقت الدكاترة والنيرسز اللي موجودين في الA&E. فيا اما بيطلعوا بيطلعوا بدون ما ينشافوا، يا اما بحسوا في الدسترس نفسه بزيد من مشاكلهم النفسية. فمنشان هيك صار في كلام كثير حول موضوع المنتل هيلث ايرجنت كير سنتر. والحقيقة انه هذا المشروع بدأ من جانيوري 25. صرنا تقريبا حوالي سنة ونص بنشتغل في هذا المشروع، وأنا صار لي 8 شهور موجود معهم ككونسلتانت. وطبعا التيم في نيرسز وفي سايكولوجيست كمان وفي سبورت وركرز موجودين مع بعض. فأنا طبعا اللي بعمله إنه كل يوم الصبح مثلا لما أروح بنطلع على البورد، هل في ناس بيستنوا medical assessments. فلما يكونوا موجودين أنا طبعا بشوفهم وبنقدم لهم العلاج، وبنطمن إنه المانجمنت بلان بيكون واضح وصريح معهم، وممكن نحولهم إلى جهات أخرى. فعملت هاي الدراسة حول موضوع اليونج بيبل، لأني لاحظت إنه اليونج بيبل مفروض يكون لهم سيرفيس معين خاص فيهم يعني. وهذا اللي أنا بحاول إني أبينه من خلال الدراسة هاي. م. آه. فزي ما بتعرفوا يعني إحنا في المنتل هيلث urgent care we support the people who comes there. And we try also some of our objectives to reduce the admissions to hospital and to find what is the best service to deal with them in the community. And during the assessment and the triage, we sometimes discharge them back to the GP, and we try to facilitate that discharge by communicating effectively with the GP regarding their clinical presentation أو their treatment. طبعا التيم ما بيحبوا إنهم يخلوا البيشنت عندهم لمدة طويلة، لأنه في البريتش عندهم 4 hours لازم يعملوا ترياج، من 4 to 6 hours لازم يعملوا كمان الاسسمنت، وخلال 8 hours لازم يكون البيشنت ديسشارج. ففي التايم ليميتد ما بيسمح انه يضيعوا الوقت، لازم انه المريض يكون ديسشارج. بنعرف انه المنتل هيلث liaison service is very effective يعني، بس حاليا في التندنسي انه الليزون سيرفيس يكون يشوف الناس اللي بيكونوا admitted to medical wards، وكمان بيشوفوا الناس اللي راحوا على A&E مثلا على Accident and Emergency Department following serious following self-harming behavior or taking an overdose يعني. كمان زي ما بتعرفوا موجود الكرايسيس ريزوليوشن هوم تريتمنت تيم they are very effective. كل هدول الأشياء اللي إحنا بنعمل معهم كمان من خلال الليزون مع هدول الايجنسيز كلهم acute services. وفي كمان الفيرست ريسبونس تيم من الادلت كوميونتي منتل هيلث تيم. في ستريت ترياج سيرفيس اللي هو طبعا ملتزم ومرتبط مع البوليس فورسز او المتروبوليتان بوليس. في الكرايسيس فانكشن تيم في الاولد ايج. وكمان شيء جديد حصل او عم بيحصل يعني في بريطانيا هون هم الكرايسيس هاوسز. يعني بنحاول انه دايفيرت الهوسبيتال ادميشن انتو ذا كرايسيس هاوس. طبعا في الكرايسيس هاوس ممكن يكون في سبورت وركرز، ما في دكتورز او نيرسز، يعني بيكون السيرفيس اللي موجود ليميتد يعني. وبنكون احنا طبعا لما نحولهم على الكرايسيس هاوس هو فور ريسبايت يعني فور ريلاكسيشن for a couple of days 3-4 days يعني. طبعا most of these services they are working 24 hours 7 days a week all the time. الناس طبعا اللي بيجونا ممكن يكونوا just walk in يعني self referrals، والأغلبية فعلا يعني بيكون self referrals. بس كمان في نفس الوقت الفاميلي دكتورز أو الجي بيز بيحاولوا لنا. البوليس ممكن يجيبوا ناس علينا يعني إذا بيشوفوا حد disturbed أو they need help in the community بيجيبوه. كمان الأمبولانس مرات they are called because of suicidal tendency for example they bring the patients to us. ومرات كثير انه احنا بوصلنا telephone calls from the NHS 111 اللي هو urgent intervention يعني من to the public. الليزون تيم كمان in the A&E بيحولوا لنا حد بعض الحالات. واحنا بنتاكد طبعا انه لما نخلص من الانترفنشن تبعتنا بالنسبه لهدول الناس we discharge them safely. في سكور بيكون once they are ready for discharge to complete سكيل، يعني بنشوف قديش التندنسي إنهم ممكن إنهم self harming in after discharge. اليونج بيبل زي ما بتعرفوا، يعني كلنا بنعرف، كلنا مرينا في مرحلة زي هيك. يعني اليونج بيبل they face some difficulties in their life. يعني can you imagine once they finish their school, they are in serious difficulties to choose what kind of studies they want to do, if they want to go to work, how they are going to be supported. يعني leaving home at the age of 18 or 19, it's not that easy. They need to depend financially on themselves. If they start a job or going to the college, they might face serious difficulties there. Some of these young people, they end up in a relationship, and that can be also confusing for them. Sometimes they struggle with motivation and performance, and sometimes they feel that they need to please others to be accepted within the group or within the class or within the job that they are doing. Some of them, as we know, they turn up into substance misuse. Cannabis is very, very common in young people. They use cannabis. Some of them, they escalate that into crack cocaine and amphetamine. And some of them, unfortunately, due to these difficulties, they end up having mood fluctuation. And they find it difficult to cope with that. Some of them, they isolate themselves. They don't attend the lectures, for example, if they are at the university or at the college. And they end up in serious difficulties with poor self-esteem, lack of confidence. And some of them, they end up with conflicts with parents because, as you know, parents always, they want their children to be in a good condition. So they are over-demanding. Now, the young adulthood, it's a phase of maturation that lasts from age 18 to 24. And there was a study from Dr. Karen Witherall at the University of Glasgow, which she managed to measure the electrodermal activity in the skin and find out how these group of young people, they respond to the anxiety and stress. The NHS Adult Psychiatric Morbidity Survey between 2023 and 24 estimated an increase from age 16 to 24 years of age. There is a psychiatric morbidity there. So they are more common in women in that particular age than in men. Now, the emotional dysregulation that we see very often in borderline personality or in some anxious patients, when emotions arouse and associated with self-harm, they can measure that in the electrodermal activity. And this doctor recruited 3 groups of patients. The first group who self-harm, and the second one, no self-harm, and the other one has self-harming ideation. And what makes a young person vulnerable to act on the self-harm thought is crucial to understand why some people transition from thinking about self-harming behavior and about acting on the thought in itself. And how is the electrodermal activity and self-harm may be related together. The study on these young people who engaged in self-harm showed a stronger physical reaction in their quality of life when they are faced with a stressful event. So there is called a pre-genetic or genetic kind of traits there. The experience in emotion arousal making it hard to regulate their emotions. And focusing on the emotion regulation strategies could be effective in managing the people who often we see in A&E, or they come to us with self-harming behavior. So there is vulnerability also of these young people to psychosis. There is a study examined 168 participants at enhanced risk of schizophrenia because of their special educational support. So they identified these 168 and they gave them the positive and negative scale of psychosis or schizophrenia. And 15 patients with psychosis, they found 15 patients with the psychosis out of 168, and they studied these 15. And what are the predictors they found that for developing psychosis? The family genetic loading, as we know, the premorbid personality of schizotypal personality traits, and obstetric factors related to the labor of these individuals. So already we have an idea about what makes young people really developing a psychotic illness. There are some predictors of that. There is a WHO study around young people. They reported that young people, if we go to the medical wards in surgery or in internal medicine, young people usually we don't see that often them in medical wards. But already they have identified the most common disability for young people, obesity and mental health problems. So psychiatric conditions, they are common according to the WHO studies in young people. We see in early intervention psychosis, we have our team around, it's called PATH. It's very good to identify these people and to refer them to PATH. They take them for up to 36 months, working with them day by day, and try not only to treat the psychosis, but also to help them having an adequate, appropriate life, really, including employment, including studies. Definitely, this has been identified as a cost-effective agency. The national statistics regarding young people in UK, they are 12% of the population. However, we know that in a country like Jordan or Iraq or in the Middle East, they are around 40 or more than 45% of this group. The peak age of onset of physical illness, we know it's around 50 years of age to 60. Definitely mental illness in young people, the peak age of mental illness occur in young people between the age of 16 to 25. Psychosis appear, bipolar affective disorder, depression. Young adults with physical health problems are more likely to have coexisting psychological problems, and they often rely on their parents for health difficulties. WHO between 1990 and 2010, physical illness in young adults is falling down, while mental health conditions are increasing. We are part of the world. This is a study in Nairobi in Kenya, and they looked at 1,900 or 1,972 students between the age of 14 to 25. And they participated in this study based on traumatic and distress scale, which is invented there in Kenya. And what they identified that the adverse childhood experiences, they call it ACE, if they have experienced abuse in childhood, emotional abuse or physical abuse or sexual abuse, if they had history of neglect, emotional or physical, if they have been brought up in household challenges, domestic violence, substance abuse by parents, mental illness, parental separation or divorce, and if there is a history of bullying, poverty, if they have been rejected from the group where they go in terms of studies, racism, community violence, as we see in many parts of the world, poor academic performance, and traumatic loss. These have been identified as adverse childhood experience, which makes the individual vulnerable to develop psychosis and possibly bipolar affective disorder. Again, there was a 4-year study, follow-up study of 8,515 children between the age of 9 and 10. The majority were male, and 78% were exposed to at least one APA, which is adverse prenatal exposure. And this is what we talk about, the reproductive system in women, including the obstetric complications. Also, they reported that ADHD that we see very often in children, their symptoms, they decrease over time. And this is why sometimes we say there are 20% who experience ADHD as a child. They might end up having the illness in adulthood, 20%. While the depressive symptoms in children, they increase with the time. And they identified the APA, which is the adverse prenatal exposure, as unplanned pregnancy, early maternal alcohol and substance abuse, complicated pregnancy, and complicated birth. These are the adverse prenatal exposure. And why I'm trying to identify that? Mainly because we have the chance to ask the individuals when we see of young age, when they come with vague symptomatology, which we are not sure about the nature of it really, that might help us to identify some vulnerability to psychosis. Again, we see often patients refer to liaison psychiatry to be seen in medical ward with abnormal illness behavior, like the functional neurological disorder or psychogenic non-epileptic seizures. And definitely in the limited time that we have during our assessment of these individuals, very unlikely to think in dynamic way. However, there is subconscious expression of painful emotions involving traumatic memories. And this could be manifested in this kind of pathology. And this may result in frequent hospital admissions. And definitely they might be diagnosed with epilepsy, for example, and they give them anti-epileptic treatment, but the situation or the condition continue without improvement. And this can lead into dependency of these individuals into the staff, the doctors and nurses. And also the stigma around the functional neurological disorder complicates life because there is no improvement, and whatever you do in terms of investigation or treatment, it's not going to change the condition. And these individuals, they suffer in silence, and they are ashamed because they spend a lot of time in these investigations, going to appointments, MRI scan, and all that kind of investigation. And very often they hear professionals saying, oh, they are, all these symptoms, they are all in their head. And there is a prescribing unnecessary medication, as we said. And often they end up in multiple admissions, which might create also a strong bonding relationship with medical and nursing staff, and they become overprotective. Now, the majority of people coming to us at the urgent care center, they are suicidal, and I will show you that in the statistics. Suicide is the common cause of death in young people, so we are taking it very, very seriously. Homicide and suicide rates have been increasing among young adults in the US. We have witnessed that, or we have seen this on the news, on the media, how firearms can be used by young people to kill others. What are the elements which might facilitate these attacks? We talk about dysfunctional upbringing. So it's important to know when we assess somebody, who brought them up, have they been in care, for example? What happened to the relationship between mom and dad? The poor schooling, they might not be able to fit within the school. Poverty also, it's a major difficulty for young people to deal with it. Unemployment, if they are not studying, why they are not working. The family history of suicide is very important, and family history of mental disorder also. And Houston in psychological autopsy found that 19 out of 27, which is 70%, had suffered of mental illness. And depression, 15 patients, they were depressed, and 8 out of the 19, they had personality disorder. Childhood physical and emotional abuse and sexual abuse also is very, very important. And we need to know how to approach the individual or the patient when we ask these questions, because very often they will not admit having history of this nature. The genetic makeup, very important. And the resilience arises from family unity. We have, for example, we see individuals who are coming from families with history of suicide, but there is the whole family, they are fully aware of that kind of risk, and they group themselves together to help each other. Predictors of self-harm, there were a retrospective observational study, and there is an association between cannabis and psychosis reported in this young age group. One finished study in 2021 at University Hospital studied 803 visits to A&E, by 631 patients. So there are a number of patients, they keep going to A&E. And 70% they had an overdose. 63, the majority were female. Benzodiazepine was prescribed and they have taken an overdose, or might be that they are buying it from the street. It's common now in Britain. Antipsychotic medication, 28% of the overdose. Antidepressant, 19%. Paracetamol, 15%. And opiates, 13%. That will indicate the way how we use these drugs or these medication when we prescribe. And very often they are used for self-harming by taking an overdose. 26% they required ICU following the overdose. Now the self-harm by cutting and self-poisoning, it's a group of individuals who really keep coming to A&E and to the urgent center. And they will tell us clearly they had no thoughts about or intent to end their life. And there are some other motives really in terms of psychodynamics. And I think this group of individuals who are young, very often they are missed in understand their psychopathology and why they are doing this kind of behavior. Now, does personality problems increase young adults' suicidal risk? I believe, based on what we see, that the suicide in itself as a risk needs to be addressed in all these factors that we have mentioned about. So we can't really just stick the point or the finger into one thing. Young adults attending the university, for example, are they at increased risk of mental illness compared with those who do not go? You know, when you finish your A-levels, your study التوجيهي الثانوي العامة، بصير موضوع بدك تروح على الجامعة، بدك تدرس، بدك تعمل، كل هاي الأمور بتخلق نوع من أنواع stress, definitely. Now, when they studied the young people who are suffering of psychosis, they were trying to find out in here, is the university in itself, going to university, has anything to do with psychosis or mental disorder? There were longitudinal study in England between 2004 and 2013 by the Department of Education. And they used the General Health Questionnaire 12. And they studied this group of individuals between the age of 16, 17, that's before and during when they ended up at the university in 18 to 21, and after when they have been graduated or left the university at the age of 25. The same group, they studied them. And what they found that the young people who attended the university at the age of 18 to 20 had higher symptoms of common mental disorders at earlier age, 16, 17, than those who did not. What does that mean? That the people who went to university and they had mental health problems already at the age of 16, they were suffering of some kind of mental illness. The study found that the rates of mental disorder in 18 to 25 group have risen from 18% or 19% in 2014 to 25% in 2024, mainly with anxiety, phobia, and OCD. So they were looking at more neurotic symptomatology rather than psychosis in here. Now, young people, suicide, definitely, it's a rare condition. But for each suicide, completed suicide, there are 100 suicidal attempts. So we can learn a lot of things from these kind of experiences. The people that we see, suicide is not easily predicted. In fact, all of us, we know when we hear about an individual who ended their life by suicide, we say, well, it never crossed my mind. ما خطرت على بالي يعني إنه هذا الزلمة أو هذا الإنسان ينهي حياته بهالأسلوب هذا. لكن negative experiences in emergency centers reinforce patients' lack of trust and poor confidence and disengagement. This has been written during a study by Owen. And the studies indicated that young people who are desperate to be shown a little of kindness and empathy. So to ensure that we understand this group of individuals, the young people, we have to start with empathy, alliance, understanding. We have to spend 5-10 minutes to create this kind of emotional rapport with them. Focus on patients' existing coping mechanisms and formulating a safety plan is essential. What we do at the urgent care center before they are discharged or went home, a nurse will sit with them and they complete the safety plan. Definitely, the substance abuse is common in young people. And I'm sure you know, these drugs have been used, most of it, including the prescribed drug, pregabalin, benzodiazepine, codeine, gabapentin. The other day, I have seen a research by a PhD student or master degree looking at quetiapine, if is considered to be an addictive drug. Right, so now when I have decided to study the group, I looked at all the patients who are coming to us at the center between September, October, November 2025. September, October, November, and this is what we have seen really. The age group, the adult young group, the blue line, here, the dark blue, 72 in September, 63 in October, and 54. Comparing with the adult age, 26 to 45, as you can see, yeah, the majority of them of that age. I looked at a specific age of the young people. Now, the total number of people came to us in these 3 months, 647. And the young age is 189. Now, I looked or break down their age. The majority, according to the percentage, were 20 years of age, 17% of the 189. And also the between 20, 21, 22, these are the majority of the young people. And I looked at the notes, and during my work, I have completed the study with them. So I looked at each one of the 189 patients with the help of the junior doctors who works with me. We looked at their gender, and surprising, they were very interesting finding. Definitely the majority were female, 341, and the male 289. But they were 4 individuals. They are not sure about their gender, if they are male or female. And they were trans female 3. So they are born male and they are transformed into female. And they were trans male 10. Trans male, so they are female biologically and transformed into male 10. This is the group the whole group. The young adult group, and we looked at their sexual orientation. The majority, or maybe half of them, they didn't say really. They don't want to be interested. But they were around half of the young group. They were heterosexual. There were 16 from the 189. They are bisexual, and they will say that. Gay and lesbian, they were 10, and transgender, there were 6 of the young group. We looked at the ethnicity. As you can see, 65% they were white. White, it could be Irish, could be English, or Europeans. I wasn't really interested to find out in exact origin. But there were 5 Asians, and around 3% they were Afro-Caribbean, mixed race, and there were around 20% or 19 they were not stated or not reported. The marital status, from the whole group, there were 51% they are single. So they are not attached, not married, living possibly alone. There were 13% partners living together. 4% they were divorced or separated. 1.3% they were widows, and 31 not disclosed. From where they came to us, these people really, as we said before, the self-referral, they are more than half the self-referral. They just walked in the urgent care center and they are asking for help and treatment and assessment. The others, they were coming from A&E, from different parts, because we are the only center in the county. So they are coming from several A&E around the county. The ambulance people, they have brought us 102 out of the 648. There were some other agencies in acute services, they brought us. The police were involved. The crisis team, they brought us some. but the majority, they are self-referrals or referred from the A&E and that is significant because the A&E, you have very busy department there. They don't have time to look at the mental disorder. And also at the same time, these people really, they wanted to talk and they wanted mental health professionals to deal with their problems. We looked at the reason for the referral as identified in the referral or when they came. And you can see 138, which is around, we'll say 75%, they are suicidal or they self-harmed or taking an overdose. So suicidality is the main problem when they arrived. And you can see 20 out of the 189, they have alcohol and substance abuse problems, anxiety. There were 3 individuals of the group, they were homeless, low mood and depression. 14 individuals, they were psychotic. And 3 individuals, they had trauma, history of trauma. So the first thing the team, they do is the triage by a nurse. And following the triage, they will go straight away into the assessment where a specialist nurse will assess the individual and they come with a specific plan. And this plan, usually, it's based on the severity of the clinical findings and what needs to be done for this individual. If there is a need to discuss it with the consultant or with the medical team, they will come to us. We are available from 9 till 5, 5 days a week. Yeah. So following the assessment, as you can see, based on the suicidality as we have seen, 51 of the 189, they ended up going to the crisis resolution home treatment team. So they required an acute service, definitely. And that means that their representation, it's appropriate, really. They discharged back to the GP, 41 of them. They have been admitted to hospital, 14. Yeah. Some of them, they were known to a community mental health team and they have been referred back to them. 6 patients, they were referred to CGL, and CGL is the alcohol service, alcohol and drugs service. New patients referred to adult community mental health team for an assessment. It's not an urgent, but they need mental health services. They have been referred as a new patient, 35. While they were waiting, 13 of them, they left the place, self-discharged. And 2 of them declined the assessment. And 3, they are signposted into voluntary kind of agencies, non-statutory, like, for example, we call MIND, or maybe there are some community centers. Now, what is the association between genetic liability for suicide and clinical characteristics following what we have seen? And there was a control study of 1,699 in New York, in Montreal, in Munich, and published in 2024, I think. Yeah. So they talk about the exposure of suicide. There is a polygenic kind of score for people who have this suicidal tendencies. And this is based on a clinical findings of hostility, impulsivity, and aggression in these young people. And the external factors could be childhood abuse and recent stressful events. And the genetic liability for suicide was associated with the internal traits like the aggression. And more severe external stressors such as the childhood abuse and traumatic experience. So it's a combination of internal and external factors. And we have to bear in mind that the genetic factor, it's always a positive to think about it and to ask during the assessment. The genetic liability for suicidal attempts may be mediated by both clinical and environmental factors. And they have also reported that the family and twin studies indicated moderate heritability of suicidal behavior. Just I want to mention about a drama, a movie drama. It's called Boys Don't Cry, which is about gender identity crisis. If you have the chance to see this movie, this is a girl. She convinced herself that she's a boy. And she started to go out with boys, playing football and going out, making fun, like any other boys, really. And during she was in her teenager, she ended up in a romantic relationship with another girl. However, during the course of their intimate relationship, the other girl discovered that she is a girl. She's not a boy. So she kept a blind eye on it. However, in the group, there were two men. They managed to find out that she is biologically a girl. So they have kidnapped her or kidnapped him, and they raped her, and then they killed her. This is a drama movie, and it's a real story, actually. The sexual orientation and symptoms of common mental disorder or low well-being. It's a study published in March 2016 in China, actually. And they talk about the sexual orientation and the gender identity. I'm sure it's interesting to find out how the young people, they end up in a drama like this. And sometimes this kind of confusion about their gender, they might drive them into suicide. So this group of patients that I have identified, I tried as much as I can to put their clinical presentation in group variables to make a sense of it. In terms of suicidality, for example, many, they had thoughts. Some of them, they have taken overdoses. There were a number of them talking in imaginative thinking about hanging themselves or jumping. Some of them, they have left suicidal notes, and some of them, they called the 999 reporting suicidal intent. So it's not that easy. I remember when I was in the clinic, we saw a young man. He was at the university, but he jumped from the M4, it's a motorway. On Monday, around 9 o'clock in the morning, when the traffic was really crowded, it's very interesting how he jumped. I saw him after he recovered from the head injury and multiple fractures that he had. A helicopter landed on the motorway to take him to Oxford University Hospital, and he was treated by the head injuries and the fractures. So one of the things he told me that no one was able to understand his suffering, because every morning, he said, my mom and dad, they were arguing for years and years. He was the only child. His dad was in civil servant working, and his mom was a teacher. So there were a lot of disputes and argument between them. And he wanted to let the whole world knows about his suffering for long years. In fact, he ended up doing that kind of suicidal attempt, and it was on the news. The whole traffic stopped in the M4. It was how many times we see helicopter landing on the motorway. It was honestly a drama, and this is what he wanted. The aggression is also important in terms of suicide, sexual assault or rape, EUBD. I think it's interesting. The transfer of care from CAMS, the children's service, into adult also, it's very, very important to know, because very often we hear that some people lost in this kind of transfer. The care pathway before the diagnosis and after, during a psychotic illness, lost in transition. And my recommendation really is to create a pathway for young adults between the age of 18 and 25 to address their psychosocial and clinical issues, including their needs. And that's my recommendation. Thank you, Dr. وليد.
شكرا جزيلا دكتور أمين على هذا العرض الرائع. الحقيقة يعني ما يلفت الانتباه هذه الريشيو العالية من gender problem و sexual orientation. I'm not sure if this is the percentage in the population or this is the percentage in patient seeking help and suicidal. لأنها يعني خبر مرعب.
أكيد. I think it's based on the study. They were in the young group, wherever they have been studying them. If it can be at the university or they followed up this group of patients. But definitely what we see nowadays in UK, the increased number of people who are confused about their gender. And some of them, unfortunately, when I have seen these 6 individuals, I went through their notes. They never asked for practical help and support to be transformed into the opposite sex. They believe that without any kind of referral. In UK, we have in King's Cross clinic, which is just for gender identity clinic. They are not prepared to do that. So it seems to me that they are more confused about their gender rather than, and this what really increase the vulnerability to to mental disorder and suicide.
نزار تفضل ميوت.
اوكي. شكرا جزيلا دكتور وليد على الاستمرار في هذه المحاضرات، وشكرا جزيلا دكتور أمين. أتحفتنا the lecture was very comprehensive and it contains a lot of information. In fact, to me, it was very good and a very nice model to do, but unfortunately, and I'm sure Dr. Walid agrees with me, in countries where services are very stretched and psychiatry is not priority at the health services, it is almost not impossible, but very difficult to really work on these fields. However, it's a good model to follow, and it is very nice. The things that really is in my mind to ask is whether the behavior, the illness behavior, and the behavior of the new generation of young adults is the same as it was 30 years ago or 40 years ago, because I find that the generations are completely different from what they were many years ago. For example, young people at the moment, especially the age category that you mentioned, 18 to 25, are still dependent on their parents because of the unemployment and because of the difficult life situations. They still live with their parents, and when they consult services, they don't come like that, either brought by police or a knock on the door of the clinic. No, usually they are brought by their parents, their relatives. And even when you draw a line for their management and you send them home, still the relatives are involved in that. I wonder whether the same thing is true in the United Kingdom. And thank you again for the great lecture.
Thank you. Thank you, Dr. Very nice to see you. And always we learn from each other. And unfortunately, what's happening in UK, the story is different. And I see that very often, that the mom comes to say, I don't want my daughter back home. They will tell us. It's common. She's an adult now. She's 18. Please help her to find her a hostel. Or so the independence living for young individuals, they are under scrutiny, really, because the parents, they can't really tolerate the distress, or they can't afford even financially to have the child. So they want their child to depend on the state, or they need to go to work. Even going to university, they can have a loan and survive on it. Yeah. So it's common, these kind of situation in UK. But regarding the mental illness, I'm not saying the British community, or we see differences between, for example, the English or the British or the white and the Asians and the black. We see differences between the communities, how they deal with close relatives suffering from a mental illness. And, you know, in London, for example, in South London, in around Maudsley and the Institute of Psychiatry, there have been plenty of research around this issue of how families, they deal with individuals suffering of schizophrenia. So the reality is that money is always an account of that, how they can manage to afford that. But there are some English people who keep their children at home while they are in need for help. We have seen them. We always in any kind of structured management plan, we involve the families as carers in the plan. Some of them, they are invited for uh, educational sessions, and some of them, they are entitled for carers assessment, which they end up having some kind of money from that. Yeah.
يعني شكرا دكتور أمين. الحقيقة الوقت تجاوزنا، لكن إذا في سؤال أو تعليق أخير قبل أن نختم. شفت الدكتور عزام عنده تعليق. تفضل دكتور عزام.
مساء الخير، أسعدتنا دكتور وليد، دكتور أمين، دكتور نزار. يعني جد أنتم يعني بتثروا أسبوعنا دائما بهالأمسيات الجميلة. لا هو يعني أولا شكرا للدكتور أمين، يعني هي مراجعة أتوقع شاملة هيك لمواضيع بالسايكايتري. أنا بزيد على اللي حكاه الدكتور نزار، بأنه بنتمنى أنه هاي المودلز تكون موجودة ببلادنا. طبعا احنا ما بنحكي انها بيرفكت مودلز، طبعا زي ما علق الدكتور أمين it does have its setbacks. بس هو تعليقي على اللي حكاه الدكتور أمين بالآخر، يعني أنت كمان ما بتلاحظ دكتور أنه a newer generation is less resilient in general للchallenges. هلا اكيد في الchanging environment بالworld today is vastly different. يعني الرابid technology اللي حصلت، السوشيال changes، الايكونوميك shifts، طبعا هذا اكيد كله تاثير. ممكن البارنتنج ستايلز كمان تغيرت وشفتد over the years. عم بتشوف البارنتس they're more emphasizing on protection و validation. فبخلي ممكن الأجيال الجديدة less exposed للchallenging. فما they don't get the chance to develop coping mechanism or resilience through their experience. طبعا بدون ذكر educational systems كيف تغيرت، وممكن كمان mental health awareness اللي كمان حدثت بآخر 5 سنين. يعني شهدنا برضو نقلة نوعية عالميا.
تمام.
والله أنا لو يسمح لي الدكتور وليد بس في نقطة واحدة. أنا اللي تفضلت فيه يا دكتور عزام، أنا أعتقد إنه psychosocial political environment يعني اللي ساعدت أو اللي diverted these young individuals of being responsible for their quality of life. يعني احنا بنشوف هون الشغله الوحيده اللي بنشوفها انه الليبر بارتي مثلا لما يكون في election their main structure to have more votes for them. How they will do that? They will go into the deprived areas and they give the impression that they are going to do too many projects, too many things for the deprived areas. The same thing happening with the conservatives, for example. They go to their areas where they have votes and they give the impression that they are going to support them. So their main objectives in that system is to have more votes. Now, when they vote for them, the reality is different. They don't face they face the real life following these kind of election, and the labors usually, or the parties in general, they try to please every category of individuals in the community. They can't do that, and this is what we end up in serious trouble. The money is always limited for funding, and we don't have the resources all the time to deliver what needs to be done. And this is why you go into medical schools nowadays, you don't see white British, very rare to see it.
I agree. نعم.
Yeah.
نعم.
I remember, Dr. Azam, when I came to this country, they were all the nurses in mental health, they were white. Now it's difficult to see a white individual doing a nursing.
صراحة mostly are Nigerian هلا بالمستشفيات.
That's true. So what's happening in the country, I believe it's more within the psychosocial political structure of,
شكرا دكتور أمين.
شكرا دكتور عزام، شكرا دكتور أمين، دكتور نزار على هاي الأمسية الثرية. نلتقي بكم الأسبوع القادم. تصبحون على خير.
تسلم
وانتم
دكتور.
تصبحون على خير.
شكرا جزيلا للجميع.